right, excellent. So quick introductions from all of you, and then we're going to jump into the thick of the conversation. We actually did a little survey of attendees here, and the idea of metrics that matter, this idea of data, analytics, insights continues to be something that's really popular, of course. We heard from Dr. Puri, the Population Health Chief Officer at Curana yesterday. He talked a lot about analytics and AI, so I'm going to get into some specifics around how we actually share data, how we gather data, how we make data actionable. And so, Daniel, do you mind doing a quick introduction, and then we'll take it down the line and jump into the meaty topic.
All right. Great to meet all of you. Daniel Krymans. I'm with SCAN Embrace. SCAN is Senior Care Action Network. It's a not-for-profit health plan largely based out of West Coast. And Embrace is SCAN's fully integrated payer and provider business unit that is solely focused on providing comprehensive primary care to seniors in senior living communities. So we do that in California and Arizona. I'm our general manager, and I'm also a physician, primary care doc by training. I somehow snuck in on the non-clinical side and took over, and it's the best job I've ever had. And it's because of the magic that really happens when you do have a plan, a provider, and an operator working together hand in hand to provide care to individuals. So I wouldn't go back. I'm not going back to brick and mortar primary care anytime soon, and just really excited to be here.
Thank you. Tom, I'm going to turn over to you.
Sure. Hi, Tom Finley, founder and CEO of Ascent Living Communities. We're a Denver-based senior living owner-operator focused on the mountain region. Started the company in 2008, and I am super excited for the next 5, 6, 7 years, whatever we have in front of us as an industry. I think it's going to be a transformative time and a really fantastic time to really change the way we operate as an industry and serve a huge population that's coming our way.
Excellent. All right, Scott, round us out.
Yeah, I am Scott Smith. I'm with Predict. Satish just kind of explained what we do. I'm a kind of a unique situation. I've actually been able to work on both sides of the table. Worked with Thrive Senior Living, Tate right here, worked with Tate, and also worked with 5-Star Senior Living before. And then before that, I was actually with IN2L before they became Life Loop. And then coming back over to the tech side with Predict. So really working with communities, with organizations of how do you take all of this data that we're going to give you and how do you operationalize that? How do you change kind of how you interact with residents when you really understand what's happening with them day to day? And so really excited to kind of dive into some of this data. What metrics should we be looking for? What's important? Why is it important? And most importantly, how do we operationalize that data to really create change for our residents?
Awesome. Thank you. So you all can see it's a pretty stacked panel. I'm just here to help guide the conversation because we have lots of experts on the stage. So I want to start with you, Tom, because I've had the privilege of sitting down with members of your team. You all have made some pretty big investments at Ascent in data and in kind of reporting, metrics, monitoring, trending. Could you tell us a little bit about like how you got started, why you got started, where you started, and maybe even some of the impact that that's had on your team and your decision making?
Yeah, sure. So we started our data journey about 4 years ago. And what we ended up doing over the first couple years is we changed out over the course of the period of time about 15 operating systems. And so, for us, it was really important as we're changing out these systems, it needs to be user-friendly on the front end, and it needs to be data-friendly on the back end. So change out all these systems, and now we've done that piece. Now we've built an internal data system that uses Microsoft's Fabric. It's a data lakehouse. All of the systems that we use have an open API, and so the data flows into the Microsoft Fabric warehouse. On top of the warehouse sits Microsoft's Power BI. And so now what we're able to do is create these dashboards that kind of go out to our residents on a daily basis. So, what does that end up looking like? Well, our teams get the data on a daily basis, and it comes to them automatically in the morning, every single morning. We track it. It's real time. It's stuff that happens. Everything that's happened from the prior 24 hours comes to our teams. And, we know that this has been super impactful with our teams. Over the last 18 months, we've seen our turnover decrease by 33% nearly at the team level. Other key metric that we've seen happen is when we look at 2023 compared to 2025 data, our average length of stay for our assisted living and memory care residents has increased by 135 days. So what are we doing? What are we giving to our teams? We're looking at a lot of the data that we were looking at before. We were looking at falls, psychotropics, hospitalizations, care refusals. Those things come to our teams every single day. But what we're also doing now is we're also looking at things like missed meds. If there's a missed med, we need to know, and we do know at the home office level, who had a missed medication, what medication was missed. The other thing we're doing is we're mining the data and we're pulling out keywords from our observation notes, and that's done. It's done with code, and so it bubbles up, and we're able to see certain things that are happening with these residents, and that way we can jump out in front of an issue before it gets sort of out of control, and we're able to really make an impact with our residents there, and really get in front of some major issues. One thing we're doing, a really important thing we do, is we want to make the data super easy for our teams to use. That's really important. So, we don't want our teams fumbling around with different technologies, trying to log in to 15 or however many different systems with different passwords and things like that. So we have a single source login that delivers all the data to the teams. And that's been super impactful. We think that making the jobs easier for the team at the community level is really kind of what we're supposed to be doing with our teams. And so we've seen our employer net promoter scores, and we've seen our manager net promoter scores jump up, near the 50 level, which is pretty high in the industry. So it's been super impactful with our teams at the community level. And then sort of what's next for us, we're looking at, resident risk scores. And so and it's not just healthcare related. We're looking at the whole of the resident. What does it look like? Not just in data from our EHR. We're looking at data from our life enrichment systems. We talked about this earlier. Are the residents attending? Are they attending activities? 2, we're looking at point of sale system. Are the residents coming to meals? Are they showing up to meals, or have we seen a change in that? Another thing we're looking at is we look at the electronic check-in system. Has a resident had a visitor in the last 30 days? So, we're taking all this data, putting it together, and creating a risk score to really see, are we going to able to jump out in front of the changes in condition that are happening and make a big difference in the residents. So, we do all this. We've got a fairly small team that's doing it right now. We have a director of business intelligence that sort of leads the charge, and earlier this year we hired a data scientist. And so the two of them kind of really run it, and it's pretty impressive. I mean, we're capturing 10,000 rows of data every single day per community, so that's a lot to sort of manage. But whenever we have these other systems in place, it makes it more manageable for us, and we're able to really make an impact.
Excellent. Thank you. Where's my friend Kathy? So Kathy, you're one of the first operators that I ever had the opportunity to learn from in this space. And wow, how far we've come. I've got Tom up here talking about APIs and Microsoft data lakes. Let me tell you, it makes my heart pitter patter. So Daniel, you are obviously running a clinical model. You have outcomes that your Scan Embrace is responsible for. You work with operators like Tom. When you hear things like what he's talking about that they're able to do, one, what information there would be actionable and insightful for you as, that provider that's ultimately responsible for the risk or the care for this resident? And then what are things that you're looking at at Scan Embrace that would actually be impactful for Tom to understand as an operator? So, you all are obviously coming at the same people, same problems, same desired outcome with slightly different data sets. But how do you think about wow, I hear this is exciting. Here's how I could supplement or complement and really get that complete picture?
Yeah, I think first, just knowing that there's an operator that's leaned into collecting that kind of data and is sharing that data with their staff and using data to drive behavior change is I already know, hey, this is a match made in heaven. We can figure it out from here. So I think that's one thing. Look, I have so much data. There's floods of data. I've got claims, I've got health outcomes data, I've got sensor data, I've got the loneliness survey data, I've got it all because I'm on the plan and the provider side. And I think actually a lot of the challenge is selecting what data and really identifying value within that data. So I'm going to put on my Billy Bean hat here.
Yes.
From Moneyball. Does anybody know what the Moneyball metric was that Billy Bean figured out at Oakland A's? What? On-base percentage. On-base percentage. So I was running the numbers from our home run derby. And I'm pretty sure it's not home runs, it's the on-base that we weren't calculating that really would select the winner. Well, joking aside, I want to challenge this group to figure out what is the on-base percentage for driving value-based care, for driving valuable care in partnership with an aligned plan or ideally provider group. And at the table, I'd love to hear what you guys have to say. My thought is it's actually something called, for us, I think it's change in condition notification rate. That's it. One measure. It's not sexy. We don't talk about it very much, but it's predictive and it's actionable. And
Can you define it for us?
Yeah, and that is, one, it assumes that you are doing the work to try to identify changes in condition. That could be loss of physical function. That could be, behavioral changes. That could be loneliness and depression, any number. But you're committed to trying to identify a change in condition. And then notification is, are you actually calling and engaging your provider group, letting them know that that change has happened before sending them out? Because I'm in over 600 communities. The paradigm that I see in a lot of the communities is when in doubt, send them out. And we need to change it to when in doubt, send them out, to when in doubt, reach out. And if you've aligned with a provider group, and you're doing that, you will be driving real value. Because one, from the resident and family perspective, you are eliminating an incredibly traumatic situation of them going to the hospital, and you're helping to prevent the loss of independence that comes with every time, it's studied, every time you send them out. Number two, in the community, what is the value too? You're increasing length of stay when they're not being sent out. And you're committing and leading into the promise that you've made to drive value in creating and supporting a high quality of life for those residents. And then three, from the health plan, each hospitalization is $16,000 to $20,000. If you can bring that care in-house, then you can really drive value. I think my time's up.
Excellent. No, thank you. Here. For my operators in the room, I'm going to make sure to advocate for you. Please pick up the phone when we reach out.
Please. You also have to find a good care provider partner, right? You can't do that if you don't have any aligned strategy. You need to have a few. It can't probably just be one, but you need to identify the providers that are really serving your residents well, align with them, and make it easy for that notification to happen so you can have a real conversation when it matters.
Yeah, very fair. So, Scott, you have a ton of experience in this space from the technology side, from the operating side as a builder. Obviously, now you're kind of that person that's responsible for helping with these technology implementations and getting a value out of the implementation of CarePredict. When you hear, Daniel and Tom talk about how they're using data, how they have so much data, share with us a little bit more. You use that magical word of operationalization. What does it look like for you? How do you partner with your operators? Daniel here said it wasn't just enough to say, I hear people talk about change and condition all the time. That's awesome. What are you going to do about it? And so tell us a little bit more about how you kind of do that partnership and that operationalization and the action of it.
Yeah, so I guess if Daniel's going to be the Brad Pitt character, I'm Jonah Hill. So thank you for that. But he was the data guy, right? So I guess it works. So one of the things that what we do with CarePredict, right, is we're autonomously gathering a lot of data. So a resident is wearing a wearable, which is something that most of us, as I kind of look around, I see smartwatches, Oura rings, Whoops. Like this is something that's kind of just part of society because it's allowing us to gather data without any additional work, right? And so that's what we're trying to do is how do we get this data without an extra workload on our caregivers or on our team. Now, that's great that we can get that data. We can put it in a nice report. We can send it over to the community. But the key part is how do I then do something with it? And so I think, for Tom, we were talking about, okay, how do we get this in front of you? The key word I thought for you was daily, right? So we were really looking at something like a change in condition. We have to understand that we have to collect enough data to understand what is baseline or norm for our residents, and then be watching this daily to see when a change of condition happens, and then have prescribed interventions that we can have with those. So for example, for us, some of the really important data that we're looking at, basic things like steps and activity levels, but also sleep. And so sleep is a key indicator of a lot of other issues that we're going to see. Falls are directly correlated to a lack of sleep. Behaviors, lack of wanting to engage, all of these things is kind of just determined by how much sleep and the quality of sleep we got before. So having that number at my fingertips that morning in my daily stand-up, who is somebody who did not sleep well, who may be flagged as a fall risk, we can have a conversation, then we can operationalize a decision. We can say, okay, today, for this individual resident, we want to make sure that we are escorting them to meals and to programming today because we know that they're at a higher risk of having a fall because their norm or they've had a change in condition on how they slept the night before compared to what they normally do. So that's a simple way, and I think daily is important, so stand up is kind of your kind of easiest way of doing that. How do I get that information in front of my team in a already structured meeting? I hear a lot of communities say, well, we have an at-risk meeting once a month, every other week. So many things could have happened in those 2 weeks or that month that could have been prevented if we were looking at this daily. And so one of the things that we're trying to do is to say, okay, you have 100 residents or 200 residents. Let me just identify the 4 or 5 that had a change in condition that you need to focus on. Mm-hmm. So one of the metrics that we're looking at is something that, that leads to UTIs. So because we are location based and we know where all residents are at all times, we're able to see how frequently they're using the restroom or going into a restroom and how long they're staying in there. And if we see a change in condition, so out of their norm, we see a difference, we're going to flag that as this person may have a UTI. And now we're not saying we need to go ahead and the intervention is a urinalysis all the time, but what we are saying is have a conversation. Talk about that in the morning during stand-up. Your director of nursing then identifies that, shares that with the team, and says, we need to have conversations. We need to put eyes on these 4 or 5 residents today. And by doing that, what we're allowing is we're taking a large group of residents and really focusing on those that had a change in condition and really being more efficient with their time. And so that's the thing. No community has the ability to continue to add more and more workload. And so the data has to make things easier for your community. So how do I then triage these 5 residents that I need to work with rather than having to kind of, talk to all 100 or 200 or whatever that may be. So I think when we start to talk about operationalizing and when I go into a community and our team goes into a community, we're really talking about how do we create less work for you, not this program or this data is going to create additional work. And I think that's the key that the community needs to hear because they're so afraid of additional work because they're kind of at their max right now.
Yeah, I think you're hitting on an important finding, and Daniel, I don't know if this has been your experience at SCAN, but my experience working at health plans is the 80-20 rule always applied. 20% of our members were driving 80% of our cost. And so, the question's always, how do we find those 20, right? How do we make sure that those are the folks that are getting the attention? And what you're hitting on here as well, Scott, is that idea of, 20% of your residents are probably driving 80% of your clinical chaos, and so how do you find them? How do you get proactive? How do you get ahead of it? I've had the awesome opportunity to be working in data and predictive analytics and data science and AI for the better part of 10 years. And I have to say, I'm still blown away by what I'm seeing with AI over the course of the last year. I actually waited out the hype cycle. I wanted to see what would really happen when it would be more interesting, when things like ChatGPT could start doing more than just, regurgitating information back to me. And I'm really excited about what we're starting to see. However, I think there's still a lot of trepidation, and rightfully so. I don't think anyone in the audience is super pumped about AI as your doctor. I'm not. And so I'd love to hear from all of you, what's your stance on how you want to use AI? Where do you think there's opportunities? Where do you perhaps have some concerns, especially, people like you, Daniel, where you're providing clinical care. No one wants to outsource their physician. So how are all of you kind of thinking about this? How are you approaching it? And then, one thing that I think would be interesting, Tom and Scott, to hear from you is, where are you even going to get some expertise in this? How are you even figuring it out? Because are you going to go ask AI about AI? And so just curious to hear from you all how you're approaching this at your organizations.
Yeah, great question. One of the things that I love about this model, when you have an aligned primary care team, is we really have the opportunity to go back to the roots of primary care, where the doctor used to know you, they used to come into your home, they knew the community. As a primary care doc, I've seen how fulfilling that is now. And I didn't have that in training, and didn't have it in brick and mortar. And so I just, that's so critical when you think about the future care workforce that's going to support our aging population. When it comes to AI, I also think of how AI can help lean into making it more like the old school primary care model. So what have we done first? We took all of the laborious administrative, time and resources around documenting these visits, which move the clinician out and away from the actual patient or the resident, and gets them back into having real conversations and real relationships. So something as simple as ambient dictation. If that solution, that tech exists, and it exists very well. I'm writing the best notes of my entire career as a physician.
Wait, you're not just copying and pasting your soap notes?
And I'm not just copying and pasting my notes. And it's from the ambient interaction that I have with my patients, the residents. But it's also then when I step out, I can have a conversation about all the other things that are going on, and it puts it into an organized, structured note with very minimal hallucination, and then also creates a note for the patient and the family so they understand what's going on. And that gives me 90+% of my time in front, right back where I want to be with the patient. So I think there's an opportunity to look into that and invest in that for the documentation burden that I know many of the staff in operator communities have. And then two, I would say you've got a ton of data and you don't even know where to start. I think there are some increasing opportunities where AI can aggregate the data in a more effective way and generate some unique insights. Now, it's a bit of a black box, but it's better than what a lot of us have now. It's just too much data, overwhelming to do anything with. So I think there's some opportunity there as well. But I would start with use it to summarize all of the documentation you're doing, and put your staff in front of the residents and have them build real relationships.
Yeah,
we've got a question up here too.
Excellent. Let's go for it.
So Evan has asked, are you using predictive analytics to look at community level opportunities for improvement? How about catching staff before they burn out and quit? So lots of this so far has been resident outcomes. Maybe that's a good question for Tom and or Scott on kind of how you're work on that.
Yeah, so there's some very simple things that we do to really help with this, which is just a simple staff survey on our app every time they log out, how was your day today? And it's a very simple score, but it gives that feedback immediately to the community. So 1 through 5, how was your day? What was your energy level? And so just by taking that number and getting a quick report to say this team member had a 2 today, which is outside of their norm, lets me reach out to them very quickly to identify the why. Was it because we were short-staffed that day? Was it they had a rough day at home? Or are they really kind of burning out and we need to kind of put some more kind of more people on those shifts, whatever it may be? So that's one of those things that we're looking at. The second is just, as Satish mentioned when he was talking, was just really that hidden care that we're not part of care plans, but the community or the team is really responsible for doing. That is taking up a lot of time that we are not accounting for in our staffing models. And so a lot of the burnout is coming because we're under, our care plans are well below where they should be, and there's this hidden care. And we may say, and again, traditionally have always said, a shower takes 15 minutes. That doesn't take into account the acuity of that resident. And so,
or how chatty they are.
Or how chatty they are, or how social they are, right? So whether that's a 5-minute, 10-minute, 20-minute, we're just saying, well, that's 15 minutes, it averages out. But, and again, that changes with time, and we're not really getting that. And so that's lost time or additional care time that we're not accounting for in our staffing model. So between those two, that constant feedback and then finding that hidden time, I think that's where we're helping with staff.
Yeah, I'd say on the staffing side, like, and I said this earlier, like, it has to be, the technology has to be easy, it has to be native to your caregiving team, or they're not going to use it, or they're not going to know how to use it. So, we've seen massive reductions in turnover. We've seen employee satisfaction go through the roof. And all my operator brothers and sisters out there, if you get that part right, everything else good follows. So these are the things that we can solve with technology and make it very easy, where you don't have the employees that leave. Or if they leave and they go to your competitor, they'll come back because their job is so much easier working for you because you've invested in this technology that makes their job easier. So that's the staffing side. On the AI side, I'd say we're still kind of at the early stages on this. I think our leadership teams are fantastic at using AI, ChatGPT, Copilot, where they can to make their jobs easier. But I know that any of us who have, entered a question into ChatGPT and it gives you a very wrong answer, and then you ask it again, and you say, oh, I thought it was this. It goes, oh, my mistake, here's this. The problem with ChatGPT is it's so authoritative. Whenever it gives you that answer, like if you don't know, then you may be getting bad information. So, on that side, we are using Copilot. We do these daily summaries that go out to our clinical team, and we have a health services director at one of our communities, and she says, when I'm brushing my teeth in the morning, I look at my Power BI report, and I know what my day is going to look like. Okay, with that report, we now have a ChatGPT paragraph that sort of talks about the things that have happened at their community in their functional department. So we're telling them what's going to happen and how their day is going to look, and it's making a huge difference. But in terms of like, are we using it just out and across the board? Not yet. And we are collecting a ton of data. As I said earlier, 10,000 rows of data per community per day. We're not necessarily doing, much with that right now, but multiply that over months, years. Then you've got some serious trending data you can use and you can work with, and these are your communities that you own that data.
Again, love hearing an operator brag about how many rows of data he's collecting every day. The key to my heart. Shameless plug. I am super fascinated around employee experience. I think that technology and AI are going to be huge unlocks for us, and not only easing the burden of our teams in these communities. We talk a lot about caregivers, but there's a lot of other folks that are providing a lot of services in these buildings as well. And I think that there's I would love to hear more from operators, to come find me if you're interested and curious, and sharing information around this. How's this manifest in your operations today? How can we use? I love being focused on the residents, but I think Tom hit it right on the head. Like when we spend time focusing on our teams, they provide a better experience for our residents, and I just think this is an awesome opportunity. So we're coming up on our breakout session. We'll be roaming around, listening. Raise a hand, grab us if you've got questions or curiosities. Obviously, wealth of experience and knowledge up here on this stage. I'm just here to help coordinate, and then we will come back and integrate.
A lot of good conversations going on out there. So what did we see out there?
I'm going to actually start calling on some tables because, as I've said many times at this workshop, nobody's safe. Mr. Eby, I saw a whiteboard. You got your thinking cap on. I think they call that a rally cap here in baseball. So I'd like to hear a little bit from your table. Do we have a roaming mic? Thank you, Coach Al.
I got it.
Bring it. Wait. Please state your table number.
We are table 10.
All right, coming in hot from table 10.
Okay, we have some good data nerds over here. We like data a lot.
My people.
And so we had a lot of good discussions. One of the ones that we had, though, is really more about the ALF industry as a whole. And so we've got some great data points. We're getting a little bit better, all providers, at capturing data. There's still some standardization, but we don't really have a way as an industry to benchmark against other providers. Which
you hearing
so
that
much
over here, my
value.
people? Were you guys cross-pollinating
Oh,
ideas?
look at that!
I love this.
Yeah, so we were like we benchmark against ourselves and we kind of see how we're doing, but it is hard to know how we are in the whole. And our SNF providers, they have quality measures and things like that they can really see that. So I think for us to really see where we're at and us to really move forward as an industry, that would be huge to have those capabilities.
May I ask you a question? Who do you think is responsible for defining those benchmarks, collecting that data, and publishing it
At the community, like at the corporate,
at the industry level?
Oh.
Like who do you all think is the appropriate kind of entity to help us decide that, right? Because I mean, look, we talk about the same things: falls, hospitalizations, blah 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 blah. But and I think it also depends on the audience too. So, how do I want to measure how great my community is doing relative to my my peers on a care quality side? How do I want to do that on a resident satisfaction side? How would I want to communicate that to Daniel at Scan Embrace so he says, oh man, I'm going to come and work in your building and we're going to help share in the value? Or how do I sell that to a consumer? Who is the appropriate entity to help define that? Do you have an idea?
Well, we've got for the nursing home sector, CMS that does a lot of that, but I would love to not have CMS more involved in what we do. I think there's some beauty in not having that regulation. So I would love that to come from the provider side and what we think just as an industry is valuable, and having some good conversations about how us as an industry can share and really evolve and move forward.
So I'm gonna take a call to action here. I'll take this action item.
Yep.
Operators who are interested in working with me on coming up with a set of benchmark data, reach out. I will happily lead the charge on helping to figure this out because I've been on a one-woman mission for the last few years
Let's go,
to solve this
Joelle.
problem.
You got
so
it,
let's
girl.
go. By the way, good ideas sound like volunteering to me.
jpo@sltc.llc.
I'll volunteer.
And so contact Joelle, and she would be an incredible person to do it. And we were also just talking about, just as providers, as operators, wanting to have more benchmarks with each other, create competitive environments within our teams, healthy competition, collaboration. And so I was like, hey, Alex, see that? I was like, you see that girl over there, Alex and Misty? I'm sure that we would share some information. Alex is a super great healthcare leader here for us at Bickford, but very competitive too. And so we need some exterior competition. So you two connect, all right?
I mean, we have
Excellent. Go for it.
Laura at Brookdale. You're, I'm sure, looking at data across your communities in the country. So I think we have people that are doing this internally. The question is do you guys want that data faced, externally? Because it comes with good and bad. We already heard we don't want CMS to control it. But I do think that having this benchmark data would be valuable, right? It gives you an opportunity to understand, where you need to get better, where you're doing well, and that is missing. So
Can I dig in on that comment about not wanting the data out there? Do we want to be transparent or we don't?
Yeah, and look, I think that there are there are lots of examples of this in other industries, right? So the one that comes to mind for me, and I'm sorry, the acronym is escaping me, but it's essentially the hospice and palliative care industry organization. And they say, hey, look, you can voluntarily participate in this. You submit your data this way. If you voluntarily participate, we're going to benchmark you against, and then we're going to give you access to this data so you can slice and dice it however you want. You can look at region, you can look at size, you can look at, and so a lot of providers participate because they're curious to see how do they stack up. It helps them make decisions. It's voluntary. No one's forcing you to do it. But if you do, you're going to get this anonymized information back that's going to help you to understand, like, how do I sell myself? How do I position myself? Where am I not performing? And so where do I spend my time? And so, there are lots of other places that have done this successfully that I think are examples that we can learn from in this industry. And so I understand this may not be for everybody. Guess what? Value-based care isn't for everybody. And so some folks will self-select, but we haven't even given people the opportunity to participate. And I'm excited to hear, because there were 3 tables that I heard talking about benchmarking, and I'm excited to hear that there's some interest there.
I'll jump in on this real quick. I think, who's the natural organization to help us with that? I think, Nick has their data set that's available. ASHA has been, publishing state of senior housing for however many, 30 years, whatever it is. Those 2 organizations, I think, have a lot of definitions. And as we were trying to create ours, we did lean on those 2 organizations, and we looked at their definitions about how they do things. The REITs also, they have a lot of information they put out there. We look to the REITs and see how they're tracking things and how they're putting their data together or have been. So that's another way to do it. But another thing you can do, is just, benchmark the data against your own communities. They're not all the same. They don't all look the same. But if you can find a few things and start benchmarking against yourself, like that's your first sort of barometer check. And that's where we sort of started, because when we started this data journey, the number of KPIs, we tracked was very few. And I'm talking just a couple. But then more you get into this, you're like, oh man, what about this? What about this? And then the creative juices just start flowing, and the whole team, this sort of culture of data will evolve within your company, and you'll be tracking stuff that you had no idea and measuring those outcomes. And it's pretty cool how quickly it happens.
Yeah, I love to say data and KPIs or metrics or anything are like the book, if you give a mouse a cookie, they're going to want some milk, right? Like I've never, ever have I put a metric in front of someone and have them been like, oh, cool, I'm satisfied, thanks. It's always why, how, da, 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 da. So it just keeps going. All right, who else? Scott, I saw you kind of digging in with a couple tables. What did you hear?
Yeah, I was talking with table 22 right over here.
Ooh, we were really table 22 in the back.
Yes, 22. So they were really talking a lot about really how to use these insights for the data they got. So really good conversation over there. They were talking about one of the operators there standing here. David, is that right? Yes, David.
Oh, look at coming to the mic. I love it.
So David was actually, and I can kind of summarize, but he can probably elaborate a little bit more. But what they were really measuring, which I thought was really interesting, was kind of the average amount of points from the care plan per resident and how that is consistent across the entire portfolio. And when that number starts to vary or get out of, I think he said 375 for his, he realizes it's a good indicator that care plans need to be updated, right? And so I'll let you kind of elaborate a little bit on my brief explanation of that. But I think it was really interesting because it was a very tangible thing that he was looking at and really going, the numbers are going to be consistent across. You might have 1 month that pops up a little bit, but there over time, if you start to see this go down, that's a really good indicator that we need to kind of start to triage some things in the community. So did you want to add anything to that?
Yeah, well, we're talking about actionable, how to use data in an actionable way and understanding whether you're capturing all the care. I mean, we all really work hard to try to make sure we're capturing the care and staff properly. So trying to use the points from the assessment as the sort of barometer of what normal is supposed to look like. And when you have enough numbers in a company, and my theory is that they don't make little old ladies in California any differently than they do in Alabama or Ohio. This is not an economic thing. It's not a political thing. It's just a thing, right? And so when you start to see variations, now you can have nurses assessing a little differently. You can get some variations like that, but it should be within a relatively tight cluster. So when you see things starting to move around and you might have some residents that move out that are very high acuity and some other ones move in that are lower acuity, but everybody else should be just creeping up as we're continually assessing their needs. And so that chart should look relatively sideways. And if it starts dipping for us, then we say, whoa, maybe we're not capturing the care. Maybe we need to go in there and take a look at that. Or when those numbers start getting out of whack, those are the kinds of things that we now need to take as an actionable step to make sure something's happening. We'll do the same thing on staffing, number of hours, or we convert that to minutes, number of minutes per point. Are we overstaffing? Maybe the points are just wrong. But using the average acuity level per resident in both memory care and assisted living is something that we can really grab onto and understand and make sure both in a staffing way and in an assessment way that we're really paying attention to that and use that in a very daily way.
Excellent. Love it. Thank you very much. Anyone else? Because otherwise, there is a table here in the front. I cannot see the number, where we have 2 electronic health record providers. And so I am deeply interested to understand
17.
What trade secrets were being shared down there at table 17, Yardy and August. So let me get a mic over to you.
I'm getting there.
Okay, thank you. Obviously, the EHR core system of record, we all live in this every day. Very key and important. So tell us a little bit about what you all were talking about relative to data.
It was an excellent table. There were some, it got a little heated. We actually, agreed on a lot of topics, and there were I think 2 main takeaways. The first that I'll focus on was someone at the table was talking about just the inundation of data that they have and dashboards and reports. And they're like, yeah, we have all the data. I think similar to a speaker on the stage, the hard part and the question was, how do you make this data, useful and actionable? And it was down to I'm a caregiver. I'm walking onto my shift today. What do? I don't want another report. I don't want another dashboard. I don't want a pie chart. I want to know that I need to do something for this resident, not even at the day level, at the shift level. So how do we take all this data? And that is a very hard problem. So I don't want to, whitewash it and say that, yeah, we have all the answers. I think this is an area that both of our companies are looking at. I think that there are opportunities here to use LLMs and some of the new technologies to parse a lot of this data. These systems are effectively tools that are very good at taking large, disparate, sometimes quantifiable and sometimes qualitative data sets and then turning them into an output about a resident. And so that's some of the work that we're doing at our company.
Yeah, when I look at that, I think the key thing there is what is it? How do we? There's different levels of actionable, right? You have your corporate level of actionable, you have community level, then you have caregiver direct care. What does action look like for them? So how do we take all this data, simplify it into one flag, one key piece, and already have kind of something that's actionable to go along with that? So this person, from all the data we have, may be suffering from depression. What is the one thing that I can do on my shift to help with that person? Or they may have a UTI. What do I need to do differently? It's in my hand. I see it. And that's one of the things that we're kind of really working on is how do we get that to the caregiver level versus just at the corporate level or the community leadership level?
And if I can add something over here.
I was like, whoa, where's she coming from? Back to table 17.
Also, what our group discussed and very much agree on, especially from the vendor side, that if you all could decide on what you want to measure, that would help all of us out on the vendor side. So very much a proponent of that. So thanks for heading that up.
Yeah, no, excellent. Look, this is the magic of this workshop, right? Is, the opportunity to say the provocative things and ask the questions and talk about the elephants that live in the room. So totally fair. And, I think my pushback to some of the vendor partners in the room is, look, I'm an operator. I'm already running a hotel, a restaurant, and a hospital, okay? I got to be an expert at everything all the time. You have one thing that you're helping. How about you help tell me what you think I should be looking at? Because you're also looking across many other operators too. So, I'm not lobbing it back, but I am saying like, hey, you guys live this all day, every day. We're looking to our vendor partners to be just that, partners, make us better, help us see around the corner, help us understand what we're not able to see because we are in the thick of it all day, every day. And so I just give us some ideas. I'm here to tell you, people are not shy. They will give you feedback. So, all right, I think that we are officially at time. Thanks, everyone, for hanging in there in a late afternoon session about data. I obviously have enthusiasm and passion around this, but I know not everyone does, so I'm thrilled to have you. And again, thanks to my expert panelists here. 3 really great, awesome perspectives, really bringing it all together and showing how we're all working collaboratively to care for our residents and our teammates. So thank you.